So hello everyone. So my name is Sungkyun Park, and I'm very happy to introduce today's speaker. So before I introduce today's speaker, so this is an environmental research seminar sponsored by Michigan Life Exposure, Life Stage Environmental Exposure and Disease Center, and then today, Dr. Ning will be talking about this PFAS and reproductive health, finding from the study of women's health across the nation. So Dr. Ning is a postdoctoral fellow, so currently working with me, and then she received MPH and PhD in epidemiologic science from the University of Michigan, Department of Epidemiology. So her dissertation research focused on environmental exposure to this PFAS and reproductive aging in a large multiracial ethnic cohort of midlife women, SWAN. And then, so Dr. Ding now expands her work to explore the roles of multi-pollutant endocrine disrupting chemicals and their mixtures, including phthalates, phenols, and parabens. Dr. Ding's research interests also include combining epidemiological methodology and novel data-driven approaches to evaluating a wide variety of environmental pollutants systematically. So please join me on welcoming Dr. Ding.
Thanks, Dr. Park, for the great introduction. And thanks, Meredith and Robin, for all the details and logistics. I wanted to thank you for giving me the opportunity to share some of the research that I've been doing with you all today. Now I'm a postdoc here at the University of Michigan. I'm going to be discussing about per and polyfluoroalkyl substances, which I'll refer to as PFAS in this presentation, and their impact on women's reproductive health, based on our findings from the study of women's health across the nation. First, I know Dr. Park has talked about this a bit. I will briefly talk about my research interests. I've worked on a variety of research projects, but the overarching theme of my research focuses on endocrine disrupting chemicals, as well as women's health. And I'm really interested in women's reproductive health, especially across the life stages. For example, not only women in their later life, as we are going to discuss today, but also reproductive aged women. And I was fortunate to work on a M-LEEaD pilot project looking at feminine hygiene products, such as tampons and pads as sources of potential toxic chemicals. And I benefit from resources from M-LEEaD and learn a lot about primary data collection during my training. And it also reaffirms my passion in women's health and environmental epidemiology. In order to link endocrine disrupting chemical to women's health, I have experience working with high-dimensional data and using multi-pollutant approaches and advanced statistical and machine learning methods to investigate chemical mixtures. Additionally, as I am trained in epidemiology, I am always solving the research questions through an epidemiologic lens. For example, using mediation analysis to explore underlying mechanisms. So today I will focus on PFAS and women's health. Before we start, let me ask you a quick question. What do pizza boxes, your outdoor gear, skis, carpets, and cosmetics have in common? Probably these four-letter words, PFAS, PFAS. PFAS are one of the most threatening chemicals ever invented. And now we are finally becoming aware that these chemicals exist and they're everywhere. When I started my PhD in 2016, there were several national and local incidents reporting PFAS in their drinking water. And that's why I started my career focusing my research on PFAS exposure and their health effects. What I want to do today is first, give you some brief background on PFAS. And then I will share our review on the effects of PFAS on the ovaries. Particularly, I'm going to talk about the effects of these chemicals on follicle growth and hormone synthesis. and I will then share our data on the effects of PFAS on menopausal timing and hormone levels in the study of women's health across the nation. Finally, I will have a brief discussion of our recent work on other health outcomes, and then leave you with some conclusions. So first, just to get everybody on the same page, I want to talk a little bit about what are PFAS. PFAS is an umbrella term for over 5,000 different manufactured chemicals, and they are commonly classified into different categories, and some of these categories include perfluoroalkyl carboxylates, such as perfluorooctanoate, PFOA, and sulfonates, such as perfluorooctane sulfonate, PFOS. And among them, PFOA and PFOS are commonly detected compounds. They do a brilliant job of repelling water, grease, and dirt, superior to any substances, which is why they are applied in industry uses and a wide variety of consumer products, including non-stick cookware and food packaging materials, waterproof clothing, furniture and carpeting, and personal care products, such as dental floss. PFAS pose a serious risk to health and the environment, and worst of all, they never degrade, and for this reason, they are also known as forever chemicals. Drinking water is also a major source of PFAS. A recent study has estimated that more than 200 million Americans, which are around 2/3 of the population, consume drinking water contaminated by these chemicals. And due to the widespread use of PFAS and their persistence in the environment, nearly every person in the US have PFAS detected in the blood, and they have an impact on practically all of us. Therefore, it is critically important to evaluate the potential health effects of these chemicals. And now we are concerned about PFAS because many epidemiologic studies have shown that they are associated with human health risks, including increased insulin resistance, higher risks of preeclampsia and preterm birth, and higher risks of obesity and chronic kidney disease. PFAS have also been identified as potential endocrine disrupting chemicals, which are chemicals that interfere with our body's hormone-making system. And previous study also suggests that PFAS can reach the ovary. However, little is known about whether they are ovarian toxicants. As a result, we're interested in the effects of PFAS on the ovaries. And let's start with a little background on why we are studying ovarian function. So the ovary is critically important for two major functions in reproduction. First, folliculogenesis, or proliferation and differentiation of follicular cells. And it makes the oocytes, or eggs, which need to be ovulated and fertilized to have normal female fertility. And it began with initiation of oocyte growth and the assembly of primordial follicles during the second and third trimesters of pregnancy. And at birth, a certain number of primordial follicles and primary oocytes are established in a resting state, consisting of the ovarian reserve. And starting from menarche, primordial follicles can grow into secondary follicles and antral follicles. Second, the ovary is really important for the production and secretion of sex steroid hormones, such as estrogens and androgens. And these hormones are responsible for the development of the eggs, implantation of the embryo, regulating menstrual and estrous cyclicity, maintaining the entire reproductive tract, and maintaining female fertility. And given the main function of the ovaries, we conducted a comprehensive narrative review of previous studies and found the potential effects of PFAS on the ovaries. Experimental studies suggested that PFAS may have an impact on these two essential processes that I've just mentioned, including ovarian folliculogenesis and steroidogenesis. So first, let's look at ovarian folliculogenesis. PFAS may have an impact on this process before birth, going through puberty and until menopause. And PFAS can lead to follicle atresia or cell death through activation of nuclear receptors, oxidative stress, or interfere with gene expression involved in the meiosis of oocytes, or a disruption of nutrient supply between granulosa cells and oocytes. Our findings suggest that PFAS may accelerate ovarian aging by decreasing the number of follicles and oocytes. And now follicles, as I said, are very important for making sex thyroid hormones. And so I wanted to share with you a summary of the effects of PFAS on ovarian thyroidogenesis. And there are two cell types in the antral follicles, the theca cell and granulosa cell. And what happens during the normal thyroidogenesis is that the theca cell taking cholesterol into the mitochondria by a factor known as STAR, or thyroidogenic acute regulatory protein. And this cholesterol is then converted by a series of enzymes to precursor hormones, eventually androgens, androstenedione and testosterone. And these androgens from the theca cell are transported to the granulosa cells, where they're converted by enzymes to the primary estrogens, estrone and estradiol. Our review of experimental studies suggests that PFAS can affect the follicles by changing expression of the enzymes required to make sex thyroid hormones. And these leads to, by and large, lower levels of estradiol production by these follicles. Additionally, our review of epidemiologic studies also suggests that PFAS may cause later menarche, irregular menstrual cycles, and reduce the level of estrogen. Although previous study examined the associations between PFAS and ovarian function, we identify several research gaps in the current literature, especially for reproductive aging. And previous studies suggest that non-menstruating women had higher serum concentration of PFAS compared to menstruating women. So it is unclear whether PFAS exposure is the cause of earlier natural menopause or the stop of menstruation leads to reaccumulation of these chemicals in women. Hence, the evidence remains insufficient to infer a causal relationship because previous studies are mostly cross-sectional studies, which are subject to reverse causality bias. Furthermore, when we're exposed to multiple PFAS, it is also important to evaluate the joint effects of PFAS mixtures on reproductive health, in addition to individual associations. Therefore, we used longitudinal data from the Study of Women's Health Across the Nation, or SWAN, to evaluate the effects of PFAS on ovarian function, in particular, ovarian aging. Before we look at our data, I will first cover a brief background into the female reproductive aging process. The ovaries are responsible for the production of the hormone estrogen, which decreases with aging. And estrogen is a major hormone responsible for affecting physiologic changes in a woman's body. And dropping estrogen levels are responsible for decreased fertility rates and depleted ovarian reserve. So then is menopause. It marks the end of reproductive lifespan. And menopause is defined as women haven't had a menstrual period for at least 1 year. We are now expanding our discussion to focus on menopausal timing or age at menopause and its associated health risks. Women will likely experience natural menopause between age 45 and 55 years, with a median age around 50. But some women reach this phase in their 30s or early 40s, while others in their 60s. And I want to highlight here that both earlier and later onset of menopause are not good things for women's health. For example, earlier onset of menopause can affect women's overall health, such as mortality rates, cardiovascular health, bone mineral density, and psychological function. On the other hand, later onset of menopause was associated with breast, endometrial, and ovarian cancer. So it is important to find risk factors related to age and menopause. And now that we've seen the health problems caused by earlier or later onset of menopause, let's look at several factors that are related to age and menopause. These include race, mother's age and menopause. Other factors include socioeconomic status, obesity, exercise habits, diet, smoking, and hysterectomy and oophorectomy. It is obvious more research needs to be done about habits and traits that impact the overall schedule. So factors that are related to age and menopause are not well understood. But it is increasingly recognized that endocrine disrupting chemicals may also play an important role. And now we will look at our data in SWAN about the effects of PFAS on menopause. The SWAN was initiated in 1996 and 97, and at baseline, 3,302 women were enrolled from 7 study sites. These include white women from all sites, Black women from Boston, Chicago, Southeast Michigan, and Pittsburgh, Chinese women from Oakland, Japanese women from Los Angeles, and Hispanic women from Newark. SWAN has approximately annual or biannual follow-up visits. The SWAN multi-pollutant study, or the SWAN MPS, was initiated in 2016 using data from the 3rd SWAN visit in 1999 to 2000, which is the baseline for the SWAN MPS. And the study was designed to examine the associations of multiple environmental pollutants with reproductive and cardiometabolic outcomes. And we have a subset of 1,400 SWAN participants from 5 sites, as shown in orange color on the map. To evaluate the effects of PFAS on reproductive aging, we need information on PFAS exposure in women reaching the end of their reproductive lives. So in the first place, using the SWAN MPS data, we describe the distribution of PFAS concentrations in midlife women and also identify their determinants. A total of 11 PFAS were measured in serum samples. And among these chemicals, we have 4 with detection rates less than 40%, as shown in red color. And all other PFAS have high detection rates, and they're included in the further analysis. We also identify determinants of PFAS in these women. For example, Black women had higher PFAS concentrations compared to other racial ethnic groups. Additionally, menstrual bleeding and parity were associated with lower PFAS concentrations. And these suggest that blood loss during menstruation and childbirth may serve as an important elimination pathway in women. Other determinants include consumption of salty snacks, for example, popcorn and potato chips, and age. And now that we've covered PFAS and their determinants, let's further look at the associations between PFAS and natural menopause. Natural menopause was defined as amenorrhea for at least 12 months, not due to hormone therapy or surgery. And we used Cox proportional hazards model after adjusting for a comprehensive list of confounders that were related to both PFAS concentrations and menopause. And we calculated hazards ratio of incident natural menopause. And PFAS concentrations were categorized into tertiles, show us T1, T2, and T3. And we found that higher PFOA and PFOS were associated with earlier natural menopause. For example, women in the highest tertile of PFOA concentrations had a hazard ratio of 1.31, which means 31% more likely to reach natural menopause compared to those in the lowest tertile. And we further calculated median age at natural menopause. And using that, we found that the 31% could be interpreted as 1.1 years earlier natural menopause. PFOS is similar to PFOA. Women with the highest tertile had 0.9 years earlier time to menopause. And here are results for other compounds. Although other PFAS show positive associations with menopause, the results did not reach statistical significance. Moreover, we consider the joint effects of PFAS mixtures. To identify subgroups with different concentrations, we used the unsupervised learning method, k-means clustering. And this method was used to find the optimal number of clusters in order to minimize within cluster sum of squares. So in this way, women with similar concentration profiles were more likely to be classified into the same group. And we use multiple criteria to find the optimal number of clusters, which results in 4 clusters, including the low group, low medium group, medium high group, and high group. Women in the low group had low overall concentration patterns, while those in the high group had high overall concentration patterns. And using results from k-means clustering, we created adjusted survival curves by clusters of PFAS mixtures and calculated the median time to natural menopause. And there are significant differences between the low and high group. Women in the high group, shown in brown color, reached their natural menopause more quickly compared to those in the low group, as shown in blue color. And the predicted median age was 52.8 years for women in the low group, while the number decreased to 50.8 years for those in the high group. In other words, women with high overall concentration patterns of PFAS reached their natural menopause 2.0 years earlier compared to those in the low group. So in the first part, we've covered the endocrine disrupting role of PFAS. And these chemicals are potential ovarian toxicants that may accelerate ovarian aging. Second, previous studies found that smoking has the most significant impact on the timing of menopause. And using the same model, we found current smokers tended to have 1.1 years earlier median time to natural menopause compared to never smokers. So PFAS show similar associations to smoking with menopause. Finally, our findings prove that these chemicals still pose significant public health concerns. As I mentioned, menopause, even a few years earlier than usual, could have a significant impact on overall health in general among women. For example, using a large cohort of postmenopausal women followed for an average of 17 years, 2.0 years earlier natural menopause was associated with shorter life expectancy with a hazard ratio of 1.04. So now we know PFAS were associated with earlier natural menopause. And in the previous part, we briefly spoke about the effects of PFAS on ovarian steroidogenesis. And let's look at that in more depth now. So first, let's talk about endocrinology of ovarian aging. Follicle stimulating hormones, or FSH, is an important part of the reproductive system. And it is responsible for growth of ovarian follicles and productions of other hormones. And FSH is a biomarker of ovarian aging, and it reflects negative feedback from a decreasing cohort of follicles and changes in estrogens and other hormones. Additionally, findings in SWAN show that in the early stages of reproductive aging, there is an increase in FSH, which serves to maintain folliculogenesis and estradiol secretion. And with further loss of ovarian function, there is marked variability in psychodynamics and in estradiol and FSH levels. Estradiol stabilizes at very low levels around 2 years after the final menstrual period. Given the endocrinology of ovarian aging, it is also important to look at the effects of PFAS on hormone levels. Our study population included 1,371 women without hormone therapy and at least one hormone measurement. And we use linear mixed model, which with adjustment for time varying age, race, and many important factors. And all hormone outcomes were natural log transformed. And also a log-based 2 transformation was applied to PFAS concentrations so that the coefficient could be interpreted as % change of each hormone associated with a doubling increase in PFAS concentrations. And we observed significant relationships between higher PFOS, PFOA, and one of the PFOS precursors, ET-FOSA, with higher FSH concentrations. For example, a doubling increase in PFOS concentrations was associated with 3% higher FSH concentrations. By contrast, PFOA and PFNA were associated with lower estradiol concentrations. And the doubling increase in PFOA levels were related to 2.4% lower estradiol concentrations. And similarly, there was 2.5% lower estradiol for PFNA. And now that we've seen significant associations of PFAS with menopausal timing and sex hormones, let's look at mediation analysis on the causal pathways from PFAS exposure to natural menopause. And these can occur through direct effects on time to natural menopause, which is defined as a part of the exposure effects that is not mediated by hormones. Or PFAS can act indirectly through changing hormone concentrations. So we conducted causal mediation analysis to explore the underlying mechanisms. Causal mediation analysis in survival setting was proposed by Tyler Vanderwell in 2011. considering the mean time to natural menopause, total effects can be decomposed into natural direct effects and natural indirect effects at the counterfactual setting, which correspond to the direct and indirect effects I've just mentioned. And we estimated the natural direct and natural indirect effects with an interquartile range change in serum concentrations of PFAS from the 25th to the 75th percentiles. And the percent mediated through FSH was 13.2% for PFOS and 26.9% for PFOA. By contrast, we found no significant mediations by other compounds or through estradiol. And these data highlight the importance of FSH in mediating the effects of PFAS on natural menopause. Taken together, we found PFOS and PFOA may accelerate ovarian aging through endocrinologic mechanisms associated with variations in FSH. Other potential mechanisms include genetic and epigenetic modifications, and also any potential mechanisms of PFAS and the menopause relationship is likely to involve an interaction of FSH and estradiol with other hormones. And the assessment of indirect effects through single mediator in the survival setting may ignore that mediating process. So future studies should account for other regulators in their analysis. A major follow-up question from our work is about potential health consequences to midlife women. While some women do not care about menopausal timing, healthy aging is important for everyone. But we know that many side effects could result from earlier onset of menopause. So it is important to link natural menopause to health outcomes. And in the next few slides, I will share with you our data in SWAN with other health outcomes. In particular, we were interested in the associations of PFAS with trajectories of body size and body fat. And let's begin with the prevalence and health consequences of obesity. And I'm sure many of you are familiar with this data. The prevalence of obesity has grown to alarming levels, both in the US and globally. So currently around 40% of the US adult population is now categorized as obese. And the prevalence of obesity contributes to a really high burden on our healthcare systems. And here in the US, it's around several $100 billion in the healthcare costs. And this is more than 14% of the total healthcare expenditures. More importantly, obesity is a risk factor for several of the world's leading causes of death. For example, in the chart, we see that it is one of the leading risk factors for death in the US. And now that we've seen the problems caused by obesity, let's look at its risk factors. When discussing about health, we often look at our diet and exercise as the key players. But we can't ignore the fact that it is oversimplistic to assume that diet and exercise are not modified by other factors. So the next question is it your fault for weight gain and obesity? Well, it is not entirely. It is increasingly recognized that stress and social pressure from peers and society may cause you to turn to compulsive eating disorders. Likewise, the environment, which is where we live and what we are exposed to. Also, certain environmental chemicals could reset body regulatory systems so as to predispose to obesity. And the idea that the environmental chemicals could be playing a role in obesity was first suggested in this 2002 publication. And in that article, they offer a compelling chart showing how closely the rising rates of obesity correlated with increasing chemical production. And there is also a lag in time. Later in 2006, the term environmental obesogens was introduced, and it is defined as a subset of endocrine disrupting chemicals that inappropriately regulate lipid metabolism and stimulate adipogenesis and fat storage, disturb adipose tissue homeostasis, leading to weight gain and obesity. And we know today about 50 chemical obesogens as shown on the slide. And you can see them in lots of places, like pharmaceuticals, preservatives, and so on. So we're interested in the potential effects of PFAS on obesity. PFAS have been shown to act through activation of fat-regulating nuclear receptors, such as peroxisome proliferator activated receptors, or PPARs. And they can also act through untargeted pathways, such as those that result in various epigenetic changes. It may further impact hormone regulation, metabolic signaling pathways, and cellular differentiation, causing increased risks of obesity. And let's further look at the association of PFAS with trajectories of body size and body fat. Our study population included 1,381 women with 15,000 repeated measures from 1999 to 2018. And the median follow-up time was 14.9 years. And outcomes included weight, waist circumference, as well as fat mass and proportion fat quantified using dual energy X-ray absorptiometry. And we found nonlinear longitudinal trajectories. So we use linear mixed models with piecewise linear splines to model the trajectories of 4 outcomes after adjusting for a comprehensive list of confounders, including socio-demographic factors, lifestyle factors, such as total calorie intake and physical activities, as well as menopausal status. And now I'd like to move on to our findings. We calculated adjusted geometric mean weight at baseline. And PFAS concentrations were categorized into tertiles, show us T1, T2, T3. And we found that the higher PFOS and PFOA were associated with larger weight. For example, women in the highest tertile of PFOS concentrations had 1.06 times larger weight compared to those in the lowest tertile, which was exactly 4.3 kilogram increase in weight. Similarly, PFOA was also associated with 4.6 kilogram larger weight, comparing the highest to the lowest tertile. Likewise, we calculated adjusted geometric mean waist circumference at baseline, and we found that the PFOS was associated with 3.6 centimeter larger waist circumference, and PFOA was also associated with 3.7 centimeter more, comparing the highest to the lowest tertile. Similarly, we calculated the mean of proportion fat because it has approximately normal distribution. And women had the highest tertile of PFOS concentrations had 1.8% higher percent fat, which was around 3 kilogram fat mass compared to those in the lowest tertile. And PFOA was also associated with around 2% higher body fat. Furthermore, higher PFOS concentrations were associated with accelerated rates of increases in weight and waist circumference during the first period. And as you can see, the number above the lines are rates of changes per year, and they are 95% confidence intervals. For example, women with the highest tertile of PFOS had an annual increase rate of 0.33% in weight during the first period, compared to the lowest tertile, which was 0.10%. So the differences in rates of changes was 0.22% per year, which was around 0.2 kilogram per year. For waist circumference, PFOS was also associated with a 0.12% differences in rates of changes over time. And similar results were observed for body fat. And here are results for other compounds. We found 2 PFOS precursors, ET-fossa and M-LEEaD show similar associations. By contrast, PFHXS or PFNA was not associated with body size or body fat at baseline. But interestingly, PFHXS was associated with higher rates of increases in these outcomes over time. In summary, in our large longitudinal cohort of midlife women with 18 years of follow-up, we found higher serum concentrations of PFOS, PFOA, and 2 precursors, ET-fossa and M-LEEaD, were significantly associated with larger body weight, waist circumference, body fat, and proportion fat, accompanied by accelerated increases during the follow-up. Along with previous findings, our study suggests that these chemicals may be an underappreciated and modifiable risk factors contributing to obesity. Moreover, PFAS can have far-reaching consequences, need more regulations. In the next few slides, I will briefly show the relationship of PFAS with hypertension and diabetes. So first, we're interested in the potential effects of PFAS on hypertension. Due to their structural similarity to fatty acids, PFAS may modulate metabolic pathways, induce oxidative stress, and endothelial dysfunction. And using Cox's proportional hazards model, we calculated hazard ratio of incident hypertension. And we found that the higher PFAS, PFOA, and ET-FOSA were associated with higher risks of incident hypertension. And the hazard ratio was 1.35 for PFAS, 1.31 for PFOA, and 1.37 for ET-FOSA, comparing the highest to the lowest tertile. Furthermore, we calculated population attributable fraction, which is defined as the proportion of all hypertension cases in our study population that is attributable to PFAS exposure when all our participants have had PFAS concentrations set at the 10th percentile. And as you can tell from the table, the population attributable fraction was around 10%, which means around 10% of the hypertension cases are attributable to PFAS exposure. Moreover, we estimated the truant effects of PFAS mixtures using quantile-based G computation. As a result, women with the highest tertile of PFAS concentrations were 66% more likely to develop hypertension compared to those in the lowest tertile. Future studies are needed to confirm our findings. Nonetheless, our findings support the view that PFAS may be an important risk factor for hypertension. Similarly, we also found higher risks of diabetes associated with higher PFAS concentrations. And the hazard ratio comparing the highest versus the lowest tertile of PFAS mixtures was 2.62. And these findings suggest that PFAS may also have a significant impact on women's cardiometabolic health. To summarize all the research work I just shared, we found the associations of PFAS with women's health outcomes, including earlier natural menopause, alteration in hormone levels, higher risks of obesity, and higher risks of hypertension and diabetes. And we also found significant associations of PFAS with irregular menstrual cycles and alteration in inflammatory biomarkers, such as adipokines. And we believe these findings have significant public health impact. First, we know that PFAS are found in most people. The associations we identified suggest that PFAS exposure should be considered as the modifiable risk factors, just like lifestyle factor for chronic disease. And the medical community should be aware of these emerging compounds. And from the point of view of population health, our findings might help identify midlife women at higher risks of chronic disease due to PFAS exposure, and might also encourage the implementation of a targeted environmental screening program. And these may provide more efficient prevention strategies. Finally, women, especially midlife women, are vulnerable to PFAS toxicity. So it is important to set up early control of PFAS exposure in women. But our next question is, how can we identify all the potential sources and lower exposure levels? One of the most dangerous ways that people are exposed to PFAS is through drinking water, because it is the major source of these chemicals that are beyond our control. Many states, such as here in Michigan, as shown in blue color, have begun the process of regulating PFAS in drinking water themselves, and have adopted enforceable standards or maximum contaminant levels for PFAS in their states. But for many other states, there is no enforceable standards, which means no need to routinely test for PFAS, and no requirement to treat water is exceeding the health standards. The Environmental Working Group have identified more than 41,000 facilities across the United States that were found discharging PFAS into the environment. Both the public and regulators have been in the dark about potential sources of PFAS, and this helps paint an alarming picture of how much PFAS is actually in our environment. And given the long half-life of these forever chemicals, especially for longer chain PFAS, we still need more data on their sources and long-term effects. Furthermore, regarding the health effects of PFAS, a better approach is to focus on disease prevention, which better ensure long-term health with attendant economic benefits. People, including myself, always have this question. What shall I do to lower my disease risks if I have PFAS detected in my blood, which is probably the case? So I want to draw an excellent example from a previous study conducted in the Diabetes Prevention Program Trial and Outcome Study. And in this study, participants were randomized into an intensive lifestyle intervention group, including reduced fat in diet and increased intensity of physical activity, or a placebo group. And they found that in the placebo group, shown in Part A, there was a significant associations between higher PFOA and higher risks of diabetes. On the contrary, no association was found in the lifestyle intervention group. And these findings suggest that an intervention of exercise and diet may attenuate the association of PFAS with diabetes. Therefore, the role of diet and physical activity provide emerging opportunities to mitigate effects of environmental pollutants on health. And last but not least, I wanted to conclude my presentation by acknowledging my fantastic mentor team and all our co-authors. And I saw some of them at the beginning of my talk: Dr. Sangkun Park, Siobhan Harlow, Bamar Mukherjee, John Randolph, Carrie Cavonan Gutierrez, Sur Batterman, and Rita Locke Caruso, as well as many of our supportive collaborators, and of course, all the participants in SWAN. So with that, I would like to stop here and open the floor for questions and comments. Thank you.
So great presentation, Dr. Ding. And so we have actually several questions, and one of them, and so ask this. So this was a great talk and an impressive body of work. So congratulations to your this extensive work. And then the first question is, you show this menopause and PFAS, and compared to high versus low, and the median age was about 1 year difference. And so this 1 year difference clinically significant, especially in thinking of the risk associated with early and late menopause?
I think the question is regarding the health implications of the differences in age and menopause, right? So as I've shown in the following slides, we have examined the questions through using the SWAN data, and there is the associations of PFAS with many other health outcomes, for example, hypertension, diabetes, and the outcome of body size and body fat, which are super sensitive to the time window of menopausal transition. And what we found was alarming, because PFAS not only contributes to earlier natural menopause with around 2 years earlier natural menopause, but also contributes to a really high high health burdens in women, like higher risks of hypertension and diabetes, and many inflammatory biomarkers, and also potential health outcomes. And I hope this answers your question.
Good. So another question. So with the understanding that PFAS, P4 can exacerbate menopause, so is there a plan for testing premenopausal women?
I think this is a very interesting question. We do conducted an analysis to look at the associations stratified by menopausal status. But surprisingly, we observe no significant effect modifications by menopausal stage, for example, pre and early perimenopause versus late peri and postmenopausal women. And as far as I know, I think our next step will focus more on postmenopausal women and later life, because we observe higher PFAS levels among these women. And at the same time, the hormonal changes during the menopausal transition may increase the susceptibility to chronic disease. I think instead of looking at more early stage, our emphasis will shift to the later life to see the effects of PFAS on potential health outcomes.
So, but not only just, this is not just a pre-post issue. So, the preventing exposure is the most important, way to reduce the risk of this PFAS. And so that's why, early detection and as well as, reducing exposure early life is the most important one. Okay, so the next question is about, so to what degree might the association with PFAS and obesity have something to do with food wrappers and fast food consumption? This is also an interesting question.
Yeah, I think this is a really good question. So I think as far as I know, most of the research on PFAS and health effects is based on two types of PFAS, PFOA and PFOS. And dietary intake is known as the largest source of exposure to these two chemicals. And there are generally two ways of dietary exposure. The one you just mentioned, the food contact surfaces, such as non-stick cookware and food packaging materials, and also general food supplies, which are also very important, like fish and shellfish consumption. And I think regarding their contribution to the obesity, in our analysis, we additionally control for fast food intake and fish and shellfish consumptions. And our results remain robust after adjusting for those factors.
Good, okay. Another question is there any evidence that the effects of PFAS on obesity, hypertension, and diabetes are reversible when PFAS intake source are removed?
This is a very interesting question. To be perfectly honest, I am afraid I don't have answer to this question. So this is more than like assuming, like more than causal inference, like assuming you have a relatively lower levels of PFAS, what would happen? We try to answer this question using population attributable fraction in our analysis of PFAS and hypertensions. And what we observe is that if we set the PFAS level at relatively lower level, like the 10th percentile in our study population, around 10% of the hypertension cases are reversible because they are caused directly from PFAS exposure. And I hope this answers your question.
Mm-hmm. And also, as you showed like a slide from the diabetes prevention program, that it's hard to eliminate all the potential source of PFAS, but there is another way to mitigate this PFAS health effect. So exercise is one of them, and then try to reduce exposure, but also other type of behavioral change can reduce potential this health effect of PFAS, especially on diabetes and obesity. So that can be another way to reduce health effect of PFAS. And then another question is, has any analysis been performed on well water vs municipality provide drinking water, so well water vs drinking water?
Yeah, so I think there are several studies looking at bottled waters, well waters, and the generally municipally drinking waters, and they found PFAS detected in all of them, unfortunately. I think PFAS should be regulated in terms of that. And as far as I know, the PFAS levels in Ann Arbor treated water below the Michigan's maximum contaminant levels, which are the good thing we want to know. Though there are still no regulations yet for some other types of PFAS.
Okay, so from the Q&As, the window, and I can see just one last question. So this will be the last one, and then this is already 12:50. So for those who have to leave, so thank you for joining this seminar, and then for those who can stay, so we will continue this Q&A. So while researching the ovaries, so did you look at and find polycystic ovarian disorder disease with increased PFAS exposure?
Yeah, I think this is a really good question. I think our study population were more focusing on women in their middle age, like the age range in our study population was 45 to 56 years. So we are not in a good position to answer this question. But in my review, the narrative review of the effects of PFAS on the ovary, we do see some studies examine the association between PFAS exposure and PCOS. And they reported a significant relationship between PFAS exposure and higher risks of PCOS. But I think another thing to consider is since the menstrual bleeding is an important determinant of PFAS concentrations, we need to be careful when we look at the study and interpret the results.
Good. And so another question just came out. And so did your study include women exposed to very high levels of PFAS in communities with contaminated water over periods of years?
I don't think so, because the range of the PFAS concentrations and the median are comparable to what we observed in the general population. For example, women of the same age range from the NHANES, the National Health and Nutrition Examination Survey. So I don't think we include women like the highly exposed community and women who are occupationally exposed to PFAS.
So yeah, so the SWAN study is just general population recruited from 5 study sites, and so this study does not include very highly exposed people. But so for your information, right now, so the Agency for Toxic Substances and Disease Registry, ATSDR, is conducting this PFAS study across the nation, and then the study side mainly focus on very highly contaminated area. So that's why once this study done, and then so they will be able to see those who have high exposure through the drinking water, and then some control group, and then how they can impact various health outcomes. Although right now it is more like a cross-sectional study, so it will take time to see how this high exposure can lead to some change in various health outcomes. Okay, so great job, and this is a very interesting question and the Q&A, and then thank you for ask this interesting question for the audience. And so we will need to continue effort to reduce this PFAS exposure, as well as reduce the potential health effect of this PFAS. So the M-LEEaD Center will continue this work as well. And then we hope to share that information through this environmental research seminar in the future. So our next seminar, which will be in 2 weeks, and we will have another interesting topic, and then so we will send that announcement soon. So have a great rest of the day, and then see you in 2 weeks. Thank you very much.
Thank you.